Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is ST elevation myocardial infarction or STEMI. Depending on presence of significant ST elevation in more than two contiguous leads, STEMI is classified as anterior wall STEMI, where ST elevation is seen in at least two leads out of lead V2, V3 and V4. Lateral wall STEMI, where ST elevation is seen in at least two leads out of lead V5, V6, 1 and AVL. Inferior wall STEMI, where ST elevation is seen in at least two leads out of lead 2, 3 and AVF. Septal STEMI is when ST elevation is seen in lead V1 and V2. Septal infarcts are usually present along with anterior wall STEMI. This entity is called as anteroseptal STEMI. In cases of inferior or septal STEMI, ECG should also be done with right-oriented leads like V3R and V4R. These are nothing but leads when placed in right intercostal spaces instead of left at same level. This is done to rule out right ventricular infarction. Posterior wall STEMI is a special one. As there are no leads overlying posterior wall, it is very unlikely that any lead will show ST elevation. In such cases, special leads oriented to posterior wall, which are lead V7, V8 and V9, can show classical ST elevation. But these leads are not routinely used. Leads which overlie exactly opposite to posterior wall, which are lead V1, V2 and V3, they show reciprocal or mirror image changes of ST elevation, that is ST depression. Posterior wall STEMI is commonly occur along with inferior wall STEMI, where it is called as postero-inferior STEMI. Similarly, there can be combinations like anterolateral STEMI, antero-inferior STEMI, inferolateral STEMI, etc. Significance of ST elevation depends on which lead it is present in. In all lead except lead V2 and V3, ST elevation more than 1 mm or one small box is considered significant. For ST elevation in lead V2 and V3, sex of the patient is taken into consideration. In male patient with age less than 40 years, ST elevation more than 2.5 mm is considered significant. Whereas if age is more than 40 years, ST elevation more than 2 mm is considered significant. To remember this, you can use the logic that for younger patient, one need greater ST elevation for making diagnosis of MI. In female patient, ST elevation more than 1.5 mm in lead V2 and V3 is considered significant. There are three phases of STEMI: hyperacute phase lasting over minutes to hours, evolved phase lasting over hours, and chronic stable phase lasting over days to weeks. In hyperacute phase of STEMI, T wave is tall, symmetrical and widened. ST slope is elevated. R wave becomes taller, or there can be distortion of terminal part of QRS complex. Ventricular activation time is increased. Ventricular activation time is time interval between start of QRS complex to tip of R wave. It is normally less than 40 milliseconds. In hyperacute phase, it is more than 40 milliseconds. There are classical features of hyperacute phase of STEMI in lead V3. There are tall, symmetrical, peaked and widened T waves, slope elevation of ST segment, and tall R waves. Although ventricular activation time is not appreciable from this image. There are tall, symmetrical, peaked and widened T waves, ST slope elevation, and tall R wave in lead V2, V3 and V4. You must be thinking on what criteria I am calling this R wave tall. To understand this, please remember that there is R wave progression from lead V1 to V5. That means R wave amplitude goes on increasing from lead V1 to V5. So normally R wave is taller in lead V2 than lead V1. R wave in lead V3 is taller than lead V2 and so on. But here R wave in lead V2, V3 and V4 are taller than R wave in lead V5. Hence these R waves can be considered as tall. On looking closely, ventricular activation time is definitely more than one small box, that is 40 milliseconds. So these changes represent hyperacute phase of anterior wall STEMI. Evolved phase of STEMI is characterized by appearance of Q wave in the form of QS, QR or QR pattern, decrease R wave amplitude, decrease ST elevation, T wave inversion, QT prolongation where corrected QT is more than 430 milliseconds. There can be further increase in ventricular activation time, and conduction blocks like LBBB appear in this phase. There are deep Q waves, decreased R wave amplitude, ST elevation and T wave inversion in lead V2, V3 and V4. This is anterior wall STEMI in evolved phase. Q wave in evolved phase represents appearance of transmural necrosis. Chronic stable phase of STEMI is characterized by maximal evolution of Q wave, persistence of small R wave, normalization of J point and ST segment, return of positivity of T wave, and normalization of QT interval, where corrected QT is less than 430 milliseconds. There are deep Q waves, small R waves, ST segment and J point almost at baseline, and upright T waves in lead 2, 3 and AVF. So this is inferior wall STEMI in chronic stable phase. Whatever we have discussed till now does not hold true for posterior wall STEMI if lead V7, V8 and V9 are not used. Normally taken ECG of posterior wall STEMI looks like this, where there is ST depression in lead V1 to V3. Mirror image of this ECG looks exactly like STEMI. So changes in each phase of posterior wall STEMI will be mirror images. In hyperacute phase, there will be deep Q wave, ST depression and deep symmetrical widened T wave inversion. In evolved phase, there is appearance of R wave, reduced amplitude of negative deflection, which would be S wave here, decreased ST depression and upright T wave. In chronic stable phase, there is maximal evolution of R wave, small S wave, normalized ST segment and T wave returns to normal negativity, especially in lead V1 and V2. Baseline abnormalities in ECG poses some difficulties in diagnosing STEMI. Most common of them is LBBB. Although recent onset LBBB in itself indicate MI, but if LBBB is there as baseline abnormality, it can mask changes of MI. Garbosa criteria is designed to help in diagnosing MI in LBBB. It takes into account 3 ECG features and points are assigned for presence of each feature. First feature is concordant ST elevation of more than 0.1 mV, that is 1 mm in at least one lead. Here term concordant means ST elevation and QRS complex both are positive. This feature carries 5 points. Second feature is ST depression of 0.1 mV, that is 1 mm or more in lead V1 to V3. This feature carries 3 points. Third feature is discordant ST elevation of more than 0.5 mV, that is 5 mm in any lead. As you must have already guessed, discordant ST elevation is when QRS complex is predominantly negative. This feature carries 2 points. Score of 3 or more suggests acute MI, while score of 2 suggests need for further investigation to confirm the diagnosis. There are wide QRS complexes in this ECG. Notch R wave in lead V5 suggests LBBB. If this patient is presenting with angina, let's apply Garbosa criteria to see if there is MI. There is concordant ST elevation in lead 3 and AVF. Out of them, ST elevation in lead 3 appears to be more than 0.1 mV. There is no significant ST depression other than in lead V2. There is no discordant ST elevation more than 0.5 mV. As concordant ST elevation of more than 0.1 millivolt is present in one lead, Garbosa score is 5. So there is acute MI in this ECG. Apart from Garbosa criteria, presence of upright T wave in lead V5 and V6 and left axis deviation in LBVB also suggest MI. Prognosis in anterior wall STEMI is worst among all types. This is because anterior wall STEMI is often associated with complications such as cardiogenic shock, left ventricular dysfunction, left ventricular mural thrombus, ventricular septal rupture, free wall rupture, pericardial effusion from free wall rupture, acute mitral regurgitation from papillary muscle rupture, pericarditis, sudden cardiac death secondary to ventricular tachycardia or ventricular fibrillation, conduction abnormalities like complete heart block, left bundle branch block, and left ventricular aneurysm, etc. There are two important complications often associated with inferior wall STEMI. Heart block, which can be second degree or complete heart block. Heart block in inferior wall STEMI are usually responsive to IV atropine or isoproterenol, but pacing may be required in unresponsive patients. Second important complication is right ventricular infarction. This is confirmed with ST elevation in lead V3R and V4R. This manifests as cardiogenic shock. This shock is due to reduced preload, hence nitrates, which causes venodilatation and further reduces preload, are contraindicated. IV fluid therapy is indicated to increase preload. Lateral and posterior wall STEMI can also be associated with complications like heart failure, arrhythmia, etc., but they are less common. Supportive care and antithrombotic treatment is same as for unstable angina or NSTEMI. Selection of method for revascularization of coronaries depends on onset of symptoms. If onset is less than 3 hours, then primary percutaneous intervention, that is coronary angiography and angioplasty, should be done as early as possible. If onset of symptom is more than 3 hours, then thrombolysis is done. Thrombolytic agents used commonly in STEMI are Streptokinase, Tenecteplase, Alteplase, and Reteplase. Although Streptokinase is not used in developed countries, it is used widely in countries like India due to cheaper cost. Dosing is 1.5 million units IV over 45 to 60 minutes. It is not clot selective. That means it activates plasminogen outside the clot also. Concern with streptokinase are hypersensitivity reaction and bleeding. Streptokinase is highly antigenic and antibodies are formed once streptokinase is administered. Hence, re-administration within 6 months is not recommended. Tenecteplase is bolus thrombolytic agent. Dosing is 30 to 50 mg IV bolus over 5 seconds. Exam dose depends on patient's weight, as shown in this chart. Tenecteplase is clot selective. That means it activates plasminogen in clot only. Re-administration can be done with caution. Reteplase is given 10 units IV bolus, 2 doses 30 minutes apart. It is clot selective and it shows faster clot resolution than any other agent. For Alteplase, there are two regimens for administration. Total maximum dose of 100 mg is given over 1.5 hours in first regimen. Dosing is 15 mg IV bolus over 1 to 2 minutes, followed by 0.75 mg per kg IV infusion over 30 minutes. Total dose not to exceed 50 mg, followed by 0.5 mg per kg over 60 minutes. Total dose not to exceed 35 mg. Total maximum dose of 100 mg is given over 3 hours in second regimen. Dosing pattern depends on patient weight. If patient weighs less than 65 kg, then dosing is 0.075 mg per kg IV bolus over 1 to 2 minutes, followed by 0.675 mg per kg IV over 1 hour, followed by 0.25 mg per kg over next 2 hours. If patient weighs more than 65 kg, then dosing is 6 to 10 mg IV bolus over 1 to 2 minutes, followed by 50 to 54 mg IV over next 1 hour, followed by 40 mg IV over next 2 hours. Alteplase is clot selective and there is lowest risk of hypersensitivity with Alteplase. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.